of you are eager to finish the session and go home early so you can have a little bit of rest during the weekend, which we spent most of it here. Anyway, it is the medical literacy session, and just I have the pleasure to introduce my colleague and my friend, Dr. Magdi Musa, and his first talk will be not all exudative AMD need to be treated. Is it true or not true? That's what Dr. Magdi will tell us about it. Okay. So, Dr. Magdi, please go ahead.
Thank you, Dr. Brahim, for the kind introduction. I hope you can hear me because sometimes there is echo in the microphones. Can you hear me? It's important that you hear me. They are hearing me. Okay. So my presentation today is about, is all exudative AMD need to be treated? Because nowadays we have a new classification of wet AMD. So we used to say this is a wet AMD with a CNV fluid, intraretinal, subretinal, and sub-RP fluid, and this is justify that this is an active CNV and need to be treated. But does all the age-related macular degeneration, even with subretinal or intraretinal fluid, need to be treated? This is a case of 59 years old female patient with bilateral progressive diminution of vision. She told me the history is 6 months. She had no systemic illness, and her visual acuity is 660, and she had no error of refraction. Anterior segment was unremarkable, and this is the fundus picture. Huge retinal pigment epithelium detachment, and there is fluid above the dome of the RPE, and there is hyperreflective lesions above the retinal pigment epithelium detachment, and we can see that underlying the RPE detachment, there is turbidity, and it is highly suspicious of CNV. This case was almost 12 years ago. And this is her bilateral picture. Look at the fundus and look at the fluorescein jug. There is late leakage. Is it leakage under the retinal pigment epithelium? Is it an occult CNV? And we can see huge drusen, soft drusen. And we can see the vitelliform-like deposits in the color fundus picture. And we can see that on the OCT in the coming picture. This is the fundus autofluorescence. We can see the linear hyper-autofluorescence lines, which is demarcating where the vitelliform deposits are, and there is the OCT where we can see the hyperreflective material overlying the RP detachment, and we can see the serous detachment shallow in the right eye and serous detachment which is evident in the left eye above the level of the RPE with notched retinal pigment epithelium detachment. At that time we don't have OCTA, and unfortunately in our country we don't have ICG, and we thought this is a CNV, definite CNV hidden by the huge RP detachment. So this is the left eye after 3 intravitreal anti-VEGF injection. There was no response. Nothing happened after 3 intravitreal anti-VEGF injection, and actually this patient was referred to me after these 3 injections. She was the mother of one of my colleagues, and he told me, can we do anything about her? I gave her 3 anti-VEGF, there is no response. And I looked at the right eye, and I said, we should not treat the right eye as long as the left eye is not responding. And we followed her up. I told him, just follow her up. And with the follow-up, she had complete resolution of or flattening of the dome-shaped retinal pigment epithelium attachment. We still can see the vitelliform lesions around the fovea, but we can see that the macula is completely flat. And the hyperreflective foci and the vitelliform-like lesion is still there. And this is 1 year later. The vision did not improve much, only 1 line barely, and we can see complete flattening of the retinal pigment epithelium with overlying disruption of the photoreceptor, and there is absorption of most of the vitelliform-like lesion. And this is the sequence of the right eye after 2 years. We still have RP detachment in the parafoveal area, but nothing happened after that, and this is 2 years later. We can see even flattening of the horizontal RP detachment surrounding the fovea, and there is mild separation between the Bruch's membrane and the retinal pigment epithelium. Here is the left eye, and follow-up, it took longer time, though this eye has been injected 3 times with anti-VEGF, and it took almost 2 years, or 1.5 years, to complete flatten the retinal pigment epithelium without any treatment. So this is an example of huge RP detachment with vitelliform deposits and subretinal fluid, which did not harbor any CNV, because if it's a CNV, it would have ended with hemorrhage, exudation, and scar tissue formation. And this is the sequence of the left eye. See how resistant it is. It takes almost 1.5 to 2 years to completely flatten. And you can see the last picture was 2013. This is after 1.5 years. So she presented to us at 2010, and we didn't have OCT angiography at that time. And at that time, 2014, this paper was published about clinical finding of acquired vitelliform lesions associated with huge RP detachment. And look at the picture, it's almost like my case. Vitelliform deposits, serous detachment. Look at the picture on the right side, it's almost like my case. And they explained that this patient are long-standing RP detachment with vitelliform-like deposits, and they flattened spontaneously. This is my case, because after 10 years, I already had OCT angiography, and I did her, and I find nothing. Because even if it was a CNV, we should have seen dead tree, filamentous vessels, but there was nothing, which means that she did not harbor CNV at any time. And this is the left eye. After complete flattening, you can see that the left eye has complete atrophy of the retinal pigment epithelium and all the outer retinal layers with bad vision in this eye, which was counting finger to 660 barely. And this is the OCT angio showing there is no flow under the retina. Here is one of my patients. Once you look at RP detachment subretinal fluid, don't think that you should not treat this patient. You have to think it might be a CNV, and you have to use all the multimodal imaging to exclude CNV. So this is only one line scan. You should not count on this, because this is other line scan, this is OCT angiography, and we can see here under the retinal pigment epithelium, there is multiple polyps. You can see high flow in the polyp, and you can see in the OCT angiography, branching vascular network ending with the small polyp. So again, this is an active CNV, so not all the RP detachment with subretinal fluid should be left alone. You have to exclude the presence of CNV, otherwise you might lose the vision in these eyes. And this is the paper I counted on in this talk. It's called non-neovascular age-related macular degeneration with subretinal fluid. We used to know neovascular fluid, non-neovascular, no fluid. Again, this is the new terminology. You have non-neovascular with subretinal fluid, and it was prepared, this study, to evaluate the patterns of subretinal fluid in eyes with age-related macular degeneration in the absence of macular neovascularization, and they found out that be aware of subretinal fluid can be associated with drusen or drusenoid RPE detachment in the absence of macular neovascularization. It may be a result of RPE separation from the Bruch's membrane and pump failure. That's why these patients accumulate fluid without harboring any CNV. And this should be put in mind. And this is from their paper. They classified the RP detachment into 3 categories. Look at the left one, middle one, and the right one. The first one, huge RP detachment by spectral domain OCT, and the fluid is above the crest, is a crest of fluid above the huge RP detachment. And it ends up with what we call complete RPE and outer retinal atrophy, which they call it C-RORA. So this terminology is coming now in the literature, C-RORA, which is complete retinal pigment epithelium and outer retinal atrophy. Sometimes they remove the C and they call retinal pigment epithelium and outer retinal atrophy. So either complete like this, or it could be incomplete with residual outer retinal layers. This is the second type of fluid. It is illustrated by OCT, where there is a noid RP detachment, and the subretinal fluid not on the hump of the RPE is located at the angle, minimal subretinal fluid. And again, they flatten after 10 months without any treatment with complete atrophy of the retinal pigment epithelium and outer retinal layers. And the third type, it's drusenoid RP detachment with low-lying drape of subretinal fluid. Look at the subretinal fluid. Sometimes it's on the hump, it's surrounding the hump, and again, it flattened with progression to C-RORA. So these are 3 types you should follow up. But again, you should exclude CNV, because they did in this literature, in this research, they did ICG, fluorescein angiography, fundus autofluorescence, fluorescein, and they did OCTA. So once they didn't find any CNV, they call it non-exudative AMD with subretinal fluid. So non-neovascular AMD with subretinal fluid, which is meant by RP detachment with subretinal fluid, describes AMD eyes with fluid in the absence of documented evidence of CNV. But it has to be confirmed by multimodal imaging. You cannot do OCT alone or fluorescein alone and say this doesn't have a CNV. And the pathogenesis, in this paper, due to hypoxia induced by RPE pump failure with accumulation of fluid, and that's why when the RPE detachment resolve, all the layers are completely atrophic because of the hypoxia, because of long-standing RP detachment. So non-neovascular AMD with subretinal fluid, it's an important clinical entity to recognize because you have to avoid unnecessary injection in this eye. Thank you so much for your listening.
Thank you very much, Dr. Magdi, for this interesting talk, actually. But I remember that in early days, we used to call it serous PED. And actually, I don't know what are the criteria of serous PED myself, apart from pigment epithelial detachment. However, the cases that you presented, it shows, okay, dressenoid PED, and it shows hemorrhage, it shows some sort of active. With all the OCT and the imaging that you presented here, sometimes it's very difficult to tell if there is neovascular membrane or not. And if you reach to the case of the doubt, is it better to treat or just keep observing while you are holding your heart, waiting for something to happen or catastrophe to happen? That's one thing. The other two comments, you said when not to treat AMD. If I say disciform scar ended up like this, that's one of the cases, maybe you will not treat AMD. And on the other hand as well, cases with, if we say loss of outer retinal layer, although there is fluid, although there is something, and the vision is counting finger, and people keep injecting in these cases, do we need to do this? Yeah, exactly.
So it's again, I mean, I have a common thing, I do it in my clinical practice. Once I inject, sometimes we used to inject because we didn't know. Once I inject 3 times and I find no results, give it some time, follow up. Follow-up will show you what will go, and especially if you do something in one eye and the other eye is exactly the same. You shouldn't hurry for intravitreal injection. Second thing, nowadays we have many tools. We used to have only fluorescein, some ICG we didn't, but ICG plus fluorescein plus OCTA, you will never miss an CNV.
One of the other things, if you have a case with RIP,
because these cases, as you said, RIP is easily to happen if they have a CNV.
Exactly.
So repeated
will you
injection.
Keep injection? That's
yes, repeated injection will be very dangerous in this because you might induce RIP instead of benign flattening of the retinal pigment.
Thank you.
So this is another point to avoid unnecessary injection.
Thank you.
Dr. Majdi, very nice presentation. Just my question, if in the same scenario where you mentioned PED with either cuff of fluids aside or on the top of it, and you mentioned 2 examples, neovascular and non-neovascular, this should be treated, this should not be treated.
Yes.
How about the same patient where you are suspecting that this is a non-neovascular and the patient is experiencing decline in visual acuity? So you are in a bit of dilemma now. The patient is experiencing decreased visual acuity, whether you
that's a good one. If
so
they have
what you will handle that?
Okay, if he is getting decreased visual acuity and the progression of fluid with progression of other manifestation like spots of hemorrhage, like exudation more, this is a warning sign. But if he is the vision is, regressing because of the flattening of the RPE. Look at the OCT. If it's completely flat after 6 months with disruption of the outer retinal layers, it means that the vision is progressive and it is irreversible. But if I suspect any signs of activity, I will repeat the OCTA and ICG again. Maybe it was a very tiny CNV I didn't detect. But in these cases, believe me, when you see a huge RPE detachment like this, or a regular RPE detachment with minimal fluid, and you follow him up for 3 months, and there is no progression, because we own CNV, there is no way to stabilize without any treatment. So it will progress. So if the fluid is increasing, any warning signs, I will do investigation again, and I will start injecting. That's a good point.
I
Thank
think
you.
this is very clear message, because I remember the nice guidelines for retreating
Yes.
the patient, not only the fluid, people only looking for the fluid all the time. And however, dot hemorrhage or new hemorrhage, that's what we call it, or reduced visual acuity,
Yes.
definitely both of them are indication for
Warning
treating
signs.
this
I mean,
patient.
this is signs you have to interfere. You shouldn't leave the patient. But again, multimodal imaging is very helpful these days. Otherwise, we are in the middle of nowhere. We don't know what to do. But again, follow-up is very good, or is mandatory in these cases, because sometimes natural course is inevitable.
Okay, thank you very much, Dr. Magdi. And can I call the second speaker, Dr. Danish Tauler, for his gene therapy in AMD? Is he here? Dr. Danish Tauler, okay, he's not here now. Let's go for Dr. Fahd Kohel, is here. And he will give us a Derby and OAK studies for dry age-related macular degeneration. And Dr. Fahd is, of course, not only a colleague and friend, and we used to work in UK together, and he is one of the people who had a lot of knowledge to present, actually. Thank you for being with us here.
Thank you very much. Can I have my slide deck? So just whilst we're waiting, so the slides I'm about to show you, they're not my own slides, but were lifted from, yes. Why have you not got it on the system? I gave it to you twice. Yeah, but sister. Anyway, sorry. So very, very quickly, these are not my slides, but I actually lifted them from the investors' website. So they're actually only recently released at the American Academy meeting, which was only a fortnight ago. But essentially, it's an anti-complement treatment for the management of geographic atrophy secondary to dry age-related macular degeneration. So we know that...
We are not here. Can you use this?
Of course.
And keep it away from your mouth a little bit so you will be better.
So we know that dry AMD, one of the pathways for particularly the development of geographic atrophy is due to complement activation. Okay? Go closer. So these are the 2-year outcomes. So again, like I said to you earlier, this drug is called pegcetacoplan. Pegcetacoplan. It's a bit of a mouthful. I'm sure the brand name will have a catchier name. But essentially, it's anti-C3. One of the there's many pathways that contribute to the pathogenesis of geographic atrophy, but one of them is complement activation. And then this particular drug, this particular company has designed it there's a hematological indication, and then they found this alternative indication in geographic atrophy. And basically, by blocking C3, C3b, you're inhibiting complement pathway activation, and in turn, reduce progression of geographic atrophy growth. So it was a big trial, about 1,200 patients. Now that I've got my microphone, I can come a bit closer to the screen. And essentially, they were randomized into 4 arms. So they either got it monthly or every other month, and then they had 2 sham arms. And the primary outcome, and that was the first time for a retinal study, was not based on visual acuity. So most of our studies, the primary outcome is the gain in vision, or the mean gain in vision in time. For this particular trial, they were able to actually look at lesion growth, and they were able to convince the FDA, the Federal Drug Authority in the US, that actually that would be a much better endpoint to determine the efficacy of the drug. And that makes sense, because we know in geographic atrophy patients, it may take a long, long time before their vision loss occurs. What we want is a drug that stops that lesion progressing, in the hope that over 5 or 6 years, that we can preserve the vision and minimize impairment from geographic atrophy. And then the secondary endpoints were reading speed, best corrected vision, microperimetry. So you had to be elderly, so over 60, good lesion size, so you were able to recruit patients with a decent amount of geographic atrophy, and they recruited patients with GA lesions, either subfoveal or extrafoveal. And obviously they excluded patients with Stargardt's. So there is this late onset Stargardt, so I think they screened for that. What was interesting is only 80% of the patients actually made it through to month 24. So that suggests that for some patients, every other month is probably too much, and they're unable to kind of maintain that commitment to that treatment regimen. But these are the outcomes, and this is the first time that we've had a positive outcome in geographic atrophy. So there was a drug developed by Roche, the name escapes me, that didn't have a positive primary endpoint. But at 2 years, you can reduce with either every other month or bi-monthly, reduce the GA lesion growth by 22%. And your efficacy of the drug is even better if your geographic atrophy is extrafoveal. And that's a game changer, because if you can detect a patient with extrafoveal atrophy and with regular treatment, slow down the progression of that geographic atrophy, slow down the subfoveal involvement of the geographic atrophy, you're hopefully going to be able to maintain the vision for longer and make a difference to the natural history. But time will tell. This is 2-year data. We need to see 3, 4, 5, 6-year data to really be confident that it's the right thing. However, this has been fast-tracked by the FDA, and they think next month or the month after, it will be ready to be introduced in American patients. But it didn't make any difference to vision, and it's not surprising. You may see that difference in vision in 4 or 5-year data, not necessarily at 2 years. And it didn't make any difference to the retinal sensitivity or the number of scotomatous points. So really, its main benefit is reducing geographic atrophy, progression or lesion growth. It's very safe. There was a small risk of endophthalmitis, and there was a small risk of intraocular inflammation, but there was no retinal inflammation. The inflammation secondary to this drug was mainly anterior or intermediate. But this is the interesting thing, is that in a small proportion of patients who were receiving monthly or bi-monthly treatment, a percentage did develop wet AMD. So that is something that you need to monitor for in the long term. But what was interesting in the trial is that they continue with the study drug as well as anti-VEGF drug. But if you're that small cohort of patients, you ended up needing potentially 2 injections every month or every other month. So it's a huge undertaking. But in summary, pegcetacoplan was slowed GA progression, at least up to 30% in the monthly and 24% in every other month, with a good safety profile, but there is that risk of exudative AMD. I think the American market will be using this, but it will be for the motivated patient, for that patient who really is able to commit to the burden of injections, and remains to be seen what will happen and how practice in the US will cope with the workload. Because I haven't shared this, but the incidence of GA is quite significant. So if we are struggling managing wet AMD, I think this will be a challenge to deliver. But let's not be. We rose to the challenge when we managed our patients with anti-VEGF. I'm sure we will think out of the box again and rise to the challenge to manage these geographic atrophy patients. Thank you.
Thanks, Dr. Fahd, for your valuable talk. Simply, anyone will definitely ask, okay, if this is not translated in visual function, definitely will stop everyone from using any drug. However, you said and mentioned clearly this could be over the 4 or 5 years by slowing the progression of the atrophy. This will maintain the vision for a long time. The other thing which worries me, okay, the incidence of neovascular.
It's about 10%. Right? Yeah, it's about 10%.
It's increased. Am I right?
Yeah, it's increased, of course.
This is a good sign or bad sign?
Well, I think it's a surprising safety signal. It just shows you why studies are really important, because you think something's a good idea. I would have predicted the intraocular inflammation, but I'll be honest with you, I didn't predict or anticipate that they'd get increased wet AMD, but they did. I don't have the data to kind of show you what happened to those patients, but I'm sure they did pretty well. I think for me, I'm much more conservative with my approach. So would I be an early adopter? Maybe in that very determined patient, but it wouldn't be something I'm going to be recommending to everybody. But if in 5 years, by giving them monthly injections, you have somebody with extrafoveal GA, you're able to give them another 3 years or 4 years of good vision, because the sham arm, it progressed. Then I think the adoption will become more widespread. I mean, thankfully, it's not such a big problem here in the UAE, but we do have European patients. We do have patients from Iran, and we have to be aware of these treatments.
My worry is just transferring someone from dry AMD to wet AMD.
Correct.
This is
correct.
Quicker reducing vision. That's the whole
thing.
I
think that's
Dr. Magdi, do you have any comments?
But it's also how do you deliver it? The GA injection 1 month, the anti-VEGF injection the other month.
Another month.
Absolute nightmare for that patient. Sorry, Magdi.
Again, if you are not giving a patient a solution, sometimes the patient will refuse that. But it's a chance to see what will happen, as you said, in 4 or 5 years. But if it increased the progression of some other pathology, the patient has to be aware of that from the beginning. Otherwise, you are, deceiving the patient. So you should tell them.
And it's interesting, we've seen drugs launch and then get pulled off the market because of the safety. So time will tell.
Time will tell.
But it's an exciting prospect. And it's the first time we've been able to make a difference in geographic
we are always
atrophy.
speaking about wet AMD, nobody speak about geographic atrophy. So
Correct.
it's another solution, because all of the people with geographic atrophy, we tell them we have nothing to do with you. So it might be in the future working.
Yeah.
It might be. Thank you so much.
No,
Thank you so
pleasure.
much.
Thank you very much, Dr. Fahd. I think the next speaker, Dr. Ahmed Salam, it is one of the topics which we always keep talking about, and we will always keep talking about. It is the management of diabetic macular edema. Is Dr. Ahmed Salam here? No. Okay. Dr. Patricio, is he around? Yes. Dr. Patricio, that's fine. Just we're waiting for you, so you can come and present your talk, because Dr. Ahmed is not here. And Dr. Patricio will give us an idea about the gene therapy in age-related macular degeneration. And it's nice to see you back, so please go ahead.
Thank you. Thank you, Dr. Ibrahim, their panel members. I expected Dr. Dinesh to come. He was also talking about gene therapy.
We're expecting a lot of people to come, but up till now, we'll carry on, hopefully.
Okay, because we got a deal. So he was going to talk about gene therapy for wet AMD.
Okay.
And,
Dr. Ahmed Salam is here, but anyway, you carry on, and Dr. Ahmed will be after. Yeah, that's fine.
and I was...
Except if you prefer to wait for
No, it's okay. I will go ahead, and if he
Okay.
comes, he can go ahead with the wet AMD.
That's fine.
Okay. So gene therapy for AMD, this only has to concern you if you're going to live long. Okay? So the best treatment for not having AMD is that you have a bad life, no exercise, full of fatty food, and die younger. So anyhow, not working? Next slide, please. Not work? Oh, no. Now, so when we talk about gene therapy, you have to think always of inheritance, okay? So for AMD, it's a disease that it doesn't have a clear-cut pattern of inheritance. Usually you have some first-degree relative, maybe in up to 25–30% of the population, but most of the cases you don't have. And I think that, as I said before, the problem is that we are living longer and longer. So the longer you live, the higher the chance. You don't have AMD when you are 35 years old. There are 30, or maybe by today, more than 30 genes involved, okay? And you can think of doing a determination of your genetics to see if you have an increased risk of having AMD and having probably a thought about a healthier life to avoid this. Well, it takes a lot of years. You have to keep the healthy life. But it doesn't really mean that having the genes, you're going to develop AMD. The ones in red are the most, let's say, recognizably associated to AMD, but these panels are not recommended to be done. Let's say my mom has geographic atrophy, but she's 96. Should I do the genetic determination? I haven't done it, and I'm not thinking of doing it. And it is not recommended so far. It doesn't change anything. So I was thinking of Dr. Dinesh. Maybe he's, I don't know if he's around. So it's a short talk, because we only have 2 molecules now that are being investigated for dry AMD as a gene therapy. For gyroscope therapeutics, they're testing the GT5, which is a protein, a proprietary protein, that actually produces expression of human complement factor I. which is a negative regulator of the alternative complement pathway. It involves putting copies of a gene producing GT5 via an adeno-associated virus underneath the retina. So the patient has to undergo a vitrectomy and then a small retinal detachment when you inject the molecule. They're only giving one subretinal injection, okay? Now they're on phase 2. Phase 2 is ongoing. And the overall objectives of the study are to evaluate the safety and efficacy, both anatomically and functionally, of 2 doses. 2 doses doesn't mean the patient is going to have 2 vitrectomies and 2 injections. It's the amount of drug you're delivering in these doses. So they have two trials, 2 arms of the trial. The Explorer will test low versus high dose, and the Horizon will check low versus medium dose. Another gene therapy currently on ongoing trials, they are still not, they still didn't open the phase 2, is that long name, which is sponsored by Himira Biosciences. This gene actually initiates the production of a glycoprotein, the CD59. And CD59 is designed to protect retinal cells responsible for vision by inhibiting the MAC, which is the membrane attack complex, the terminal step of complement-mediated cell lysis. Phase 1 study is finished, but still we don't have the results. It's a single intravitreal injection, which sounds, I hate intravitreal injections, by the way. I mean, I cannot think, where's Dr. Kohler? I cannot think of being 30 years, because I'm going to live long, 30 years every month getting injections. I would commit suicide. I mean, no way, no way. We have to find another way of treating this. And phase 2 is planned for subjects with advanced AMD, with GA, and they will be randomized in a 1:1:1 ratio comparing intravitreal high versus low dose versus sham. And the recruitment is still not open. So, in conclusion, it's not only genetics, okay? It's epigenetics. Your lifestyle, what you do, will change the outcome of the expression of these genes that are going to produce in some people age-related macular degeneration. As you can see here, we recommend fruits and vegetables, carotenoids, fish and nuts, some supplements if you want. Keep the weight, like I'm doing. Don't put yourself on weight. Do not smoke. And the difficult part is to exercise. Okay? So go for a walk, go for a run, cycling, swimming, whatever you like, but do exercise. And thank you so much.
Thank you very much, Dr. Patricio. Actually, when it comes to the gene therapy, I always feel different emotions. What I'm saying is, first of all, it is one of the most challenging areas in ophthalmology, okay? And when I compare this, for example, to hereditary retinal disorders, and after years and years of research, we managed to get RP65 Luxturna, and I used it. We did in Cleveland, waiting for something to happen. The maximum you achieved in this patient is sensitivity of light, and they managed to move, which is mandatory for them, because some of them, even they couldn't move here or there, but you couldn't do anything for the visual acuity or the colors or any other issues. But when it comes to AMD, this patient will never lose vision completely because all the peripheral retina is completely fine. They will navigate, they will move, they will maintain something else or whatever. And do you think really gene therapy will have a role here, especially with the high cost? What I mean, usually the gene therapy, we are talking, for example, Luxturna, $800,000 $400,000 each eye to achieve this little bit of target. And the EMD patients, the numbers even would be much, much, much higher. And the cost for the treatment would be, again, very high for them. And to give them what, that is the question. And I don't know what is coming in the future, but it's all...
Well, the future is going to be darker because, as I said, we are going to have a longer life. So the longer you live, the more cases you will see. It's the same problem as for the pensions in Europe and the States. It's impossible. It's impossible. Imagine that maybe the normal average lifespan of a person in 25 years down the line is 100 years. Imagine of the numbers of AMDs we are going to have. So I think that we have to change something, not forget about, I mean, if we can get something with one injection, that's great. I would sign now, but I don't believe it. I don't believe it. And we have to change something. I don't know exactly what, but we have to change something. I wouldn't live too much long. I wouldn't live 500 years, for example. Imagine being married to the same woman for 400 years. It's impossible.
The other thing is, okay, the genome testing that people start to do it early in life or whatever to see these genes are here and you are liable for this and this and this. Do you think any one of us will be willing to know that this can happen for him at any time? What I mean, for example, the famous story about whoever detected the genes for breast cancer and she decided to take her breast before the cancer is there or not. Will it be a dilemma, big dilemma, just to know that I have potential for this and this? Will you live in peaceful way by knowing this, or you prefer not to know anything about it?
I would rather prefer not to know. I want to think that it is in God's hands, and I don't want to know.
It's a dilemma, but you know, the latest years has given us two things, artificial intelligence and gene therapy. Artificial intelligence is not as cost effective as this one. The problem is that because this is a virus vector which is incorporating your gene therapy that is implanted either intravitreally or subretinally. The problem is not just the cost, the problem is the technical preparation of this one, and so I'm not sure how clinically we can implement and make it available for everybody in the near future. It's going to take a long time. The technology is there. Now it is for specific genes. It might incorporate a bigger number of genes. But I always suspect the clinical implication of this gene therapy to vast majority. Maybe it will be very limited to special clinical scenarios and special socio-demographic scenarios. But I doubt it will be available for the general population.
Yeah, I agree. I mean, if you think of the world, just forget it.
One of the main drawbacks of the gene, because even we know there is some people can benefit from this, but we couldn't give them because of the cost and the restrictions on the therapy and which one we should give and should not. Do you have any comment, Dr. Magdi?
No, but I always say that 10 years ago we didn't have any solution, or 15 years ago for wet AMD. Now we are speaking about gene therapy. Let's look for the future. I mean, let's be optimistic. Someday you will have something there, and probably not this. Probably something else will revolutionize everything. Probably someone else.
Completely agree. I mean, this is only one small step forward, but I mean, it's not the end solution.
This lecture is when your patient asking if there is any treatment for dry AMD. Yes, it's coming in the future. Dr. Patricio gave us a lecture. 5 years later, we will have the solution. Thank you so much.
Most welcome. Thank you.
Thank you very much, Dr. Patricio. Now I can call Dr. Ahmed Salem. And yeah, that is the topic that we definitely will have opinions, and we can talk about our patients, and we can always keep it in mind. It is updates in diabetic maculopathy management. So please, Dr. Ahmed. Oh, okay, Dr. Osman first. Okay, that's fine. Because for the table that I have here, it is for Dr. Ahmed to talk about the buttons. Dr. Osman now.
Yeah,
okay,
Ibrahim, thank you very much.
Dr. Osman Mahmoud, and I think he will give us an idea about the updates in DME management, what is at present and what's...
Hi, good afternoon, ladies and gentlemen. Thank you very much, Ibrahim. I think we'll kickstart quickly. It's nothing special, but just a quick overview of the updates in diabetic macular edema and the treatment. Let me see if it can work. Okay, I just want to acknowledge the paper, the work done by Usha Chakravarti, and this talk basically is contains what her work was and the paper was. So I have no financial interest in the talk. So DME, it's a major cause of visual impairment, as we know, and intravitreal treatment currently, as we all retinal specialists know, is a gold standard. So diabetic eye disease, it entails diabetic retinopathy and diabetic macular edema. And it can occur at any stage of diabetic retinopathy, and it can also be a sole manifestation. So we are all aware of the clinically significant macular edema, how it was classified, but now things have moved on from there. So it's since 2018, ICO, International Council of Ophthalmology, classified DME as number 1, no DME, number 2, non-center involving DME, and center involving DME. So what is the pathophysiology? We all are aware of the retinal pigment epithelial and Müller cell dysfunction, the breakdown of the blood-retinal barrier, capillary non-perfusion, and neuronal damage. So what are the vasopermeability markers in DME? As we know, it's VEGF. Monocyte chemotactic protein level seems to be related to severity of DME. Intracellular adhesion molecule levels in aqueous are related to greater macular volume and interleukin-6. So what are the ideal treatment features? It should be well tolerated and safe. It should improve and stabilize and maintain useful vision in the long term. It should restore the retinal macular morphology and reduce the treatment burden and the cost. There are a number of treatment and clinical trials we are all aware of, and we have come to a point where we know that there is a first-line treatment, which is anti-VEGF, and we have plenty of them. Second-line intravitreal steroid implants, dexamethasone and ILUVIEN. And third-line are the lasers. Conventionally, we use the focal, grid, or micropulse, or combination. So do the number of injections matter? Yes, they do. It have shown that the benefit of DME treatment is directly related to the number of injections. What are the current optimal treatment regimens? Currently, as all the retinal specialists, they treat as either TAE, which is treat and extend, which is a loading dose with a fixed treatment intervals in between, can be adjusted according to the clinical response, or PRN, which is the loading dose followed by close monitoring. So the difference between the two is that treat and extend is a proactive component as compared to the PRN, which is a reactive treatment. Retreatment criteria are still under debate. Do we consider decreasing vision or OCT findings? Generally, it is accepted that it's the central retinal thickness due to increase in SRF, or both are the signs for retreatment. What are the EU Retina guidelines? Recently, they've been published regarding the ranibizumab and bevacizumab for the DME. Should get monthly injections till the vision and the OCT is stable. And aflibercept treatment is monthly 5 doses, loading doses followed by the bi-monthly in the first year. And then the dexamethasone implant can be used in the pseudophakic patients, which are suboptimal response or unsuitable for anti-VEGF, and should also be used in the first line in case of patients with severe cardiopulmonary disease and recent MIs, and also the patients with poor compliance. So what are the current unmet needs? Still we have patients with suboptimal response in spite of multiple injections, in spite of changing the molecules, recurrence of DME after the withdrawal or extending the treatment intervals. We know that the capillary non-perfusion remains the same. It doesn't get better even with the anti-VEGF treatment. So the ideal treatment should have fewer injections. It should increase the efficacy and durability and minimize the side effects. So what are the newer molecules now? As we are aware, already started using ranibizumab, which is a single chain fragment. And I don't want to go into these trials. The Fresimab has already been mentioned, is a biphasic antibody. There is interesting molecules coming up. The more interesting I found is the one which is right at the bottom, PAN 9030806, which is a selective anti-VEGF agent delivered topically once daily, and that probably could be a game changer if it is successful. So in summary, currently effective treatments are available. We need medication with longer duration, sustained effect with disease remodeling, and the search for new target molecules hopefully will probably answer this issue. Thank you very much.
Much, Dr. Osman. If you don't mind, just we'll keep the discussion now until Ahmed presents his case, and both of you will answer all the questions about diabetic edema just to present the time. Dr. Ahmed Salam, can you please come just?
Thank you so much, and delighted to be here. Would you be kind to get my presentation? It's called DME Salam. Okay, I'll skip actually the majority of my presentation because it was covered by Osman very nicely, and I'm very lucky that he did it more elegantly than if I could have done it. So again, it's similar to the article he presented. We wrote a review article on the same topic, which summarizes the same topic. I'm just going to touch on 2 points, really. And let me skip here. One is the combination therapy. And I think this seems to be happening, and I'm seeing this happening more in the States with using a different combination. And the thought is that if you use a steroid and anti-VEGF in particular, then maybe you're having the benefits of the two. The steroids works on more than a pathway, not only the anti-VEGF, and then you're having that prolonged effect of treatment with less use of anti-VEGF. And that's what we saw in the Paladin study, which was published this year. And it showed that if you have a fluocinolone acetonide in the background and you use an anti-VEGF, then you can actually, as a rescue therapy, if the Iluvien fails, then you can have a smaller number of anti-VEGF treatment, and that was about like 1 treatment per year in the 36 months. So it shows that you can decrease the number of injections. So that's really maybe of interest to try to have a steroid in the background and use anti-VEGF. The other thing which I would like to touch on, I mean, again, he touched also on the faricimab, is what's the role currently of parasplenometrectomy? And it remains, as was seen before, if it's a tractional component and the macular edema is not responding to anti-VEGF treatment. Because even if you have a tractional component there and it's obvious, I would still try anti-VEGF treatment because like what we see in uveitic macular edema with traction, sometimes they just respond to treatment. But if it's not responding to maybe, let's say, 3 or 4 anti-VEGF injections and there's significant traction component, then these cases may benefit from vitrectomy. The other question is if you have a refractory diabetic macular edema, but there is no traction, would that benefit from vitrectomy? In my humble opinion, no. And I think there's no really direct evidence that says, yes, they do benefit from vitrectomy in the absence of traction. A few things you need to be wary of. Anti-VEGF, the response becomes slower. That was found in several studies, including the DRCR-NET, one of the studies, because the wash is quicker if you have a vitrectomized eye. But the half-life of Iluvien and Ozurdex is not affected after vitrectomy, which is really something nice, that they still work very well. And thank you so much.
Thank you. This is very short and sweet,
Yes.
and actually it is a lot of discussion. Dr. Osman, if you please come here so we can have a discussion if anyone, Dr. Osman left. Anyway, you are here. Simply, you mentioned user and Paladin. You mentioned Paladin, not user, but user and Paladin, both of them were observational studies for the people who will have Iluvien or whatever. Actually, I have one comment here. In UK, when Iluvien came to the market, I used to use it a lot, and it was effective.
Yeah, and you've
fine.
published on that, right?
Exactly.
You and,
especially,
and
there was, dexamethasone was not licensed for diabetic macular edema at this time, and we didn't use it, and we used Iluvien straight away, anti-VEGF Iluvien, and it was absolutely perfect. However, when I came here and I started to use Iluvien again, I just noticed the response is not as good as I used to be, especially here it is in the American license, you have to use dexamethasone first, test if the patient will respond, and then you can move to long-acting steroids. And interestingly, in few cases, the response was great with the dexamethasone, and it's not this as great as when you move to Iluvien. And here you have to have the adjuvant therapy that you mentioned, what I mean, you go into VEGF or whatever. One of my big explanations for this is the daily dose release of dexamethasone is 11 microgram per day, which is high dose, compared to 2.5 in Iluvien, the daily dose release. And here, some patients simply will need higher dose of steroids to control the diabetic macular edema compared to the others, especially in this area of the world where the hemoglobin A1C can reach 9, 10, 11 easily without any problem. So in this case, can I apply the same rule that I prefer using Iluvien with adjuvant therapy, where I can use one type of steroid, which I don't need adjuvant therapy with? This is just the main question, actually.
ابراهيم انا اسف لسبب انا مش سامعك كويس هنا الصوت وحش قوي بس انا I understand انت you're saying that Iluvien may not work as well, right?
Here, yeah, because some people will need higher dose of steroid, and dexamethasone maybe work better in this case.
I agree, and I think we see this in uveitis as well, that Iluvien with this constant slow release may not as work as Ozurdex, which I think really works better as an initial treatment. And I think how things are going in uveitis, if you really need to quieten the eye quickly, you give Ozurdex. Then if you want to have a longer acting medicine, then you give Utiq or Iluvien. And I think same applies for diabetes. I don't think Iluvien works in every case.
Yeah,
but Ozurdex does work in the majority of cases, but the duration is shorter.
Exactly. Fahd, do you have any comment? Because you use Iluvien a lot, like me as well.
Just to second Ahmed's point, so in uveitis, if I do use Iluvien, I've often suppressed the inflammation with Ozurdex. So I've often suppressed the inflammation with Ozurdex before I introduce the Iluvien in, because if you look at the baseline characteristics of those patients, they didn't have significant anterior chamber inflammation or significant vitritis when they were given Iluvien. So Iluvien is definitely very good in reducing your frequency and need for additional treatment, but you need to suppress the uveitis first before you introduce it. With regards to diabetes, I only ever used Iluvien when I gave at least 3 to 4 anti-VEGF injections, and I definitely saw less than a 5-letter improvement in vision or a less than 20% reduction in central retinal thickness, because there I could be very confident that they had an insufficient response to the anti-VEGF, that this was inflammation, and I would give the Iluvien straight away. Because in 2013, was it 2013 when it was first launched in the UK, we didn't have Ozurdex licensed at that point. Fast forward to a year or two ago, I would give an Ozurdex and then give an Iluvien, and I still had really good success rate. I've only recently moved to the Middle East, so I haven't necessarily observed Ibrahim's observation, but it may be that here in the Middle East that the inflammatory DMO is much more active, and maybe Iluvien isn't immunosuppressive enough. But if you're going to use Iluvien, pick the right patient so you can be very confident that it will work.
One of the main problems that we'll face here as well, I'm not sure if you are having the same problem in America or not, is the insurance.
Yes.
Because simply when you say to them, I'm going to give Iluvien, which is 30,000 dirham,
Yes.
they're expecting from you, okay, this will work for 2 or 3 years, and that's the reason they will approve it for. But when you come after a few months and say, I need to top it up with anti-VEGF or whatever, you have to justify why you are doing this all the time. And this is one of my main problems that I'm facing as well.
Maybe you can refer to the Paladin study, but yes, we don't have the same problem. I mean, we have to try a steroid before to confirm that the pressure did not go up. Then you can use Iluvien for diabetic macular edema. That's how it was approved by the FDA. But insurance usually allowed to use an anti-VEGF afterwards. But maybe you can refer to that study that shows you need rescue treatment.
Of course, that's what we're doing,
Yes.
but it's hassle every time, I'm afraid.
Dr. Salam, excellent presentation. Due to shortage of time, I have just 2 clinical questions, because DME is very important in this part of the world. First, in your opinion, what is the definition of non-responder with respect to visual acuity, OCT, or duration in terms of months? And the second question, very clinical, when you have active DME going on and you have a patient who needs cataract, so how would you approach that preoperatively, intra, post? Just two way.
Great questions. I think the answer for the first question is really, I would say it's about 4 injections, and I base it mainly on OCT, because there are other factors that may govern visual acuity improvement, including ischemia, for example. So I would say 4 injections and based mainly on OCT reduction, and you want to see at least 50% to 100%, 100 micron change to feel like there's a response happening. The second question, I think anything you do will be correct, but you have to start some treatment before the cataract surgery. You have one patient who would listen to you, whatever you say, let's treat this until we get the significant improvement in macular edema, then move on to cataract surgery, and the patient would listen. And you have the other patient who's really very edgy, and after 1 or 2 injections, they need their cataract surgery out because they want to see. And I think that's fine. You can give them a couple of injections and maybe the 3rd injection with the cataract surgery and continue afterwards. But I think the wrong thing would be to say, let's do the cataract, then think about the macular edema later. So I think anything you can do, the first 2 scenarios are very optimum.
Thank you. Do you have any comment, Dr. Magdi? Okay, that's fine. Thank you very much, Dr. Ahmed.
Thank you so
we'll go to the next speaker, Dr. Amin Marashi. Is he here? Yes, okay. And he will give us novel indications for suprachoroidal injections. So, Dr. Amin, please come.
Can you start my presentation, please?
The last one.
Yes.
So, Dr. Amin, do you mind just we'll do Dr. Towel while they are preparing, and just to save the time, while they are preparing this, he can do his talk and then you can do your talk.
Shall I start talking?
No, I'm not saying stop talking. I'm just saying just to save the time while they are taking time to do this. Okay, there is Dr. Towler here as well, so I will give his talk and then we'll go to you because we're approaching the end of the session. Eh? Who? Yeah. So we have to make it short, Dr. Towler, please, because simply we are running time. Okay, that's fine.
Could you please attach this? Could you please attach this?
Okay. Yeah. Okay, Dr. Amin, so please come ahead. That's fine. Good. So it was quick, which is great. That's fine.
Okay, I'm gonna today talk about the suprachoroidal injection novel indications, as suprachoroidal has been utilized to inject triamcinolone. But today I'm gonna talk about other particles. I have no financial interests. We all know that Clearside has done multiple clinical trials to utilize the suprachoroidal injection to treat diabetic macular edema, injecting triamcinolone, and the macular edema related to retinal vein occlusion, and they gained the FDA approval in a Peachtree trial where they treated macular edema related to uveitis. But let's talk about other molecules, like a small molecule. Small molecule axitinib is in the suprachoroidal space is highly potent TKI that inhibit vascular endothelial growth factor VEGF R1, R2, and R3. So it provides a pan-VEGF inhibition activity. OASIS is a clinical trial to assess the safety and tolerability of a single dose of suprachoroidal axitinib that found it is tolerated in patients at no serious complications and with a long-acting potential, which reduce the treatment burden on neovascular AMD. What about gene therapy? We all know that when we want to inject genes under the retina, we need to do pars-plana vitrectomy to detach the macula and to inject the molecule. But with suprachoroidal, we can do this in office. So we can deliver the gene therapy under in the suprachoroidal space, and it can be effective as the subretinal surgery. So the phase 2 AVIATE trial for the treatment of neovascular AMD and the phase 2 ALTITUDE trial for treatment of diabetic retinopathy assessing suprachoroidal delivery of RGX 314. The initial data were positive in both trials. 47% that treated with RGX 314 demonstrated two-step improvement from the baseline of the ETDRS diabetic retinopathy severity scale at 6 months compared to 0% of patients in the observational control. What about oncology? AU011 is photoactivated via non-thermal infrared laser light. It induces cell membrane disruption, acute cancer cell necrosis, and a long-term anti-tumor response. AU011 via suprachoroidal administration in patients with choroidal melanoma, and preliminary results support a positive safety and tolerability profile. But the question here, if we want to utilize the suprachoroidal injection in our practice, do we need the clear side injectors? The answer is no. We can invent our own microneedles. The sky is the limit. For example, this is my needle. The principle is I'm allowing only 1,000 microns out of the 30 gauge needle. I created this rubber with the tip of the insulin syringe. You can do yours. The idea is not allowing more than 1,000 microns. Why the 1,000 microns? Because to reach the suprachoroidal space in a lot of population, it's about 930, 960 microns. So with 1,000 microns, we should, at the pars plana, of course, we should go into the suprachoroidal space. Did I do my own studies? Yes, I've treated, I treated solar retinopathy in a young girl. After observing her for 1 month, she was suffering from scotoma and reduced vision, and after the suprachoroidal injection, the scotoma has gone and improved vision to 20/20. I treated the diabetic macular edema post-pars-plana vitrectomy. So it was a retrospective case series, and I had wonderful results. And a pseudophakic cystoid macular edema post-injection. So you can create your own needle and do a novel indications beside the diabetic macular edema and macular edema related to retinal vein occlusion and posterior uveitis. Thank you for listening.
Thank you, Dr. Amin. One quick question. Do you think the suprachoroidal approach will not increase the intraocular pressure as it used to be the intravitreal approach?
Yes, for two reasons. The first reason, there is a less interaction with the anterior chamber. The second of all, the drainage of the aqueous happens at the suprachoroidal space. So the steroid here won't stay more than 8 weeks. So the efficacy is only 8 weeks.
But there is no procedure without complication, right? So there is no procedure without any complication.
Yes, you can have an increased intraocular pressure, but it's more predictable. I never had an increase or more than 30.
How about hemorrhage in the choroid?
Suprachoroidal hemorrhage, it's impossible because I'm injecting at the pars plana avascular. I never had this complication at all.
Thank you. Thank you so much.
Thank you very much, Dr. Amin, for the interesting talk. Okay, Doctor. Yeah, so this is the last talk actually for Dr. Danish Taylor, and as I said, we are approaching the time, so our apologies for those who are coming after because we started late, so we're nearly there, so just only 5 minutes.
One second. One second. Good. Good afternoon, ladies and gentlemen. This is something which is for the future. What do we have in mind? We know at the moment the mainstay of our current treatments for AMD are anti-VEGF agents. But how does an anti-VEGF agent get produced? Now, if you go into its production, you'll realize basically we use mice who are immunized with a vascular endothelial growth factor. That creates a monoclonal antibody to the VEGF, which is then isolated by RT-PCR. And then this is put into a plasmid, which is transferred to an E. coli. And once it's transferred to an E. coli, we then harvest the anti-VEGF agent from there and then use it. So schematics of present treatment are the gene for the drug is manufactured, transferred to a bacteria. The bacteria which produces is the factory, and that is harvested and transported to the clinics where we inject it into the eye. On the other hand, the future treatments could be the same gene is produced, transferred to the site of pathology, which is the eye. The drug is produced in the eye, which is now the factory, and direct action is there on the pathophysiological process. So one injection takes care of the pathology for the life of the patient. Is that a fantasy, or is that something possible? Well, the feasibility was shown by voretigene neperforec, that is Luxturna, which was used when they transferred a gene using adenovirus into the photoreceptor cells, and found that it works in these patients who have congenital amaurosis or RP with a retinitis pigmentosa with a RP65 mutation. So the question arises, if the DNA can be inserted into photoreceptor cells to treat the deficiency created by a defective gene, why can't we insert the same DNA material that produces the anti-VEGF agent into the retinal cells to have a continuous source of anti-VEGF agent instead of harvesting it from an E. coli? And basically, what we are talking about is from gene replacement for inherited retinal degeneration to gene therapy to create an ocular biofactory. And once we want to see this, two things are needed to check the feasibility. One is, can we manufacture this genetic material? The two is, can we transfer this genetic material? So we know that we can produce the material. We are already doing it for ranibizumab aflibercept. And the Avalanche study showed that you can inject it into the cells and produce the drug. And it does help to decrease the number of rescue treatments. Currently, there are already two treatments available for gene therapy for AMD. One is using Adverum biotechnologies, which produces aflibercept, and the second is Regenex Bio, which produces ranibizumab. The Adverum technologies had an optic study which showed that yes, you can have a durable and sustained efficacy of the treatment with this gene therapy, and the vision can be maintained or improved. Not only that, the retinal anatomy is also stabilized, and if you check for the aflibercept in the eye. After this, you do an anterior chamber tap, and you can actually find aflibercept up to 104 weeks after a single injection. So this helps to, this works. The proof of concept is therefore there. And the only thing they needed to do in some patients, they needed to give steroid treatment, but it was mainly topical. In some patients, it was with the lower dose, it was a smaller amount of time, and with the higher doses, they had to give it for a longer period of time. When they used the same for diabetic macular edema, they've had one case of what they call a serious unexpected adverse reaction, which is a word of caution. That is not that we know how to manage this, but we do know that it works. We can decrease the number of injections in 85 to 96% of patients. So it's a great thing. Now, the Regenex Bio program gives ranibizumab, and they've tested with 5 different cohorts, different doses. They found a significant reduction in anti-VEGF treatment, and they found that this is stable for up to 2 years. So the only significant side effect they found was some pigmentary changes in the periphery of the retina, not even in the center, and no inflammation. So the important thing is that this works. The number of injections goes down. The vision can be improved for a significant number of patients, and the ongoing trials are still there. The important thing is how to give the drug. So you can give the drug intravitreally, you can give it subretinally, or you can have a suprachoroidal delivery. The intravitreal has the advantage, that's the easiest way to do it. We've been doing so many intravitreal injections. The disadvantage is that there's less penetration. Just finishing, last 2 slides. Subretinal is more privileged, but it needs a full surgery, and suprachoroidal obviates the need for surgery. So the important thing is that the subretinal space is the most effective site for delivery. If you're giving intravitreal, there's some reactions can occur, or if you give suprachoroidal, less efficacy, so you may have to give a greater amount of dose. We already have proof of concept. We have phase 3 trials now going on, and we hope that soon we'll have more these drugs available, except we don't know how much they'll cost. I think Dr. Patricio has already talked about dry ARMD, which is another beautiful concept which may help us. The fact remains that newer developments in gene therapy are likely to change the way we manage our patients with AMD in the future, and also for diabetic retinopathy. So we are living in very exciting times. Thank you very much, ladies.
Thank you very much, Dr. And unfortunately, we don't have enough time to discuss anything, and sorry for whoever coming after for the delay, and it was great to have you all here.